Hello friends, today we will discuss the topic metabolic alkalosis. And in metabolic alkalosis, actually what happens, there is a increased arterial pH and there is a rise in bicarbonate concentration, and the compensating mechanism in the metabolic alkalosis is usually rise in PaCO2 because of alveolar hypoventilation. And you talk about the compensatory mechanism, for each 1 mmHg rise in serum bicarbonate, the PaCO2 increases by 0.5 to 0.6 mm of Hg. Now this metabolic alkalosis can be a simple metabolic alkalosis, or it can be mixed, present as mixed disorder, like it can coexist with metabolic acidosis, respiratory acidosis, or respiratory alkalosis. Then we will talk about what are the causes of metabolic alkalosis. So causes of metabolic alkalosis is, first cause is because of the exogenous bicarbonate load in condition with acute alkali administration and the milk alkali syndrome. The second is effective ECF volume contraction, normotension, and the potassium deficiency and hyperaniemic hyperaldosteronism. So in the second category, the ECF will be contracted and the patient will be having normotension, there will be hypokalemia, and there will be hyperaniemic hyperaldosteronism. So it can be divided into two further causes, like those with the gastrointestinal origin and the renal origin. In patients with gastrointestinal origin, the cause is usually the vomiting, gastric aspiration, the congenital chloroduria, villus adenoma, and laxative abuse. So these patients will have loss of, in patients with vomiting, there will be loss of HCl, and as well as in patients with the gastric aspiration, there will be loss of hydrochloric acid. In patients with congenital chloroduria, there is a loss of excessive chloride in through the gut because of defective channels and in the ileum and the colon, and which are responsible for the secretion of chloride in exchange with the bicarbonate. And same mechanism in the patient with villus adenoma, there is a increased chloride secretion in patients with villus adenoma. And the last is the laxative abuse, and such patients usually have the extracellular volume contracted state because of decreased consumption of oral fluids, and thus leads to the ECF contracted volume and metabolic alkalosis. Now the causes of renal origin. First is due to the use of diuretics, especially the thiazides and the loop diuretics. So they will cause excessive free water excretion that leads to the ECF contraction. Second is the recovery from the lactic acidosis or ketoacidosis. So in such patients, lactate and the keto acid, they will be converted into the bicarbonate. Third is actually the potassium depletion. We will study how the potassium depletion will leads to the metabolic alkalosis. Fourth is because of the magnesium deficiency, and fifth is because of syndromes like Bartter syndrome and the Gitelman syndrome. In Bartter syndrome, there is a loss of function mutation in the thick ascending limb of the loop of the Henle in the sodium potassium 2 chloride cotransporter. In the Gitelman syndrome, there is a loss of function mutation in the sodium chloride cotransporter present in the DCT. So this will cause, both this syndrome will cause a loss of the solutes and along with the water, and that leads to the extracellular fluid volume contraction and leading to the contraction alkalosis. And the last is the carbohydrate refeeding after the starvation. Now the third category is ECF expansion, hypertension, potassium deficiency. There could be the high renin or low renin, and hyperaldosteronism. So in this category, we have divided it into further two, like those with the high renin level, like the patients with the renal artery stenosis, accelerated hypertension, and the renin secreting tumor, and those with the low renin levels. Low renin levels, these patients, they will have the low renin level, increased aldosterone, potassium deficiency, hypertension, and the ECF expansion. So the primary causes of these are the primary aldosteronism, which can be due to the adenoma, carcinoma, hyperplasia, or glucocorticoid suppressible hyperaldosteronism. And secondly, it could be due to the adrenal enzymatic defects like 11 beta hydroxylase deficiency, or there could be the 17 alpha hydroxylase deficiency. And third is because of the Cushing syndrome or the Cushing disease. And since in Cushing syndrome there is an excessive secretion of glucocorticoids, and this glucocorticoid, they also have the mineralocorticoid activity that leads to the hyperaldosteronism and leading to the metabolic alkalosis. So now the question is how this hyperaldosteronism causes the metabolic alkalosis, and the mechanism is it causes basically the reabsorption. Aldosterone causes the reabsorption of the sodium and the excretion of the potassium, and this potassium will be again reabsorbed in the collecting duct and in exchange with the H plus ions, so that will lead to the metabolic alkalosis. And the other causes are ingestion of licorice, which contain glyceric acid, and the carbinoxolone, and the smokeless tobacco. Fourth category is the gain of function mutation in the ENaC channels, and that leads to ECF expansion, hypertension, potassium deficiency, and the hyporenemic hyperaldosteronism. And the cause is basically the Liddle syndrome. So in the causes of metabolic acidosis, you should see four things. First is the extracellular fluid volume status of the patient, whether the patient is volume in contracted state or the patient is hypervolumic. If the patient is a volume contracted state, then you should think of whether GI causes are responsible or the renal causes are responsible. In the GI causes like vomiting, increased gastric aspiration, and there could be the laxative abuse, and there could be the congenital chloroduria and the patient with villous adenomas. And in the renal origin, you should think of the use of diuretics and the potassium depletion, the magnesium depletion, Bartter syndrome, Gitelman syndrome, and the recovery from the lactic acidosis or the ketoacidosis. And if the ECF volume is expanded, then you should see what is the blood pressure of this patients, like the patient is having hypertension or not, and the patient is having potassium deficiency or not, and lastly you should see the renin, angiotensin, aldosterone system, whether this patient they are having the high renin, low renin, or the hyperaldosteronism. So if the ECF is expanded, and the patient is having hypertension, we have already discussed what are the various causes. Like in the patient with the high renin, the causes can be renal artery stenosis and the renin secreting tumors. These are the main causes. And the patient with the low renin should think of primary hyperaldosteronism related causes, or the other causes like Cushing syndrome, and there could be the enzymatic defects and the ingestion of licorice. And sometimes this metabolic alkalosis can be due to the Liddle syndrome, and such patients will present with gain of function mutation in the ENaC channels, leading to ECF volume expansion, hypertension, potassium deficiency, and hyporenemic hyperaldosteronism. These patients will be having low renin hyperaldosteronism. This is a characteristic feature of these patients. Now we talk about what are the phases of metabolic alkalosis? So first is the generation phase and second is the maintenance phase. In the generation phase, what happens? This can be due to the either due to the loss of the H plus ions in the urine or the GIT, or there could be the H plus ion movement into the cells. So alkalosis can occur in the two conditions. First there can be the loss of bicarbonate. There is patient is taking bicarbonates, or there is a loss of H plus ions. So this loss of H plus ion can occur in the urine or GIT, and or there could be the H plus ion movement into the cells. And secondly, the patient is taking sodium and potassium bicarbonate. Now, sometimes it can also result from the administration of sodium or the potassium citrate or lactates, such as sodium citrate is mainly used in the during the FFP transfusion or during the blood. It is mainly used as an anticoagulant, sodium citrate. So you should think whether if the patient has been given the multiple blood transfusions or multiple FFP, so that can be the one cause of metabolic alkalosis. And volume contraction around a relatively constant bicarbonate, this is known as the contraction alkalosis. And usually in this there is a loss of excessive water, either from the urine or from the gut, and with no loss of bicarbonate, or relatively that leads to the contraction alkalosis. Now in the maintenance phase, what is usually if there is generation phase of metabolic alkalosis occurs, then the kidney tries to compensate for this compensate for the metabolic alkalosis, and in this the kidney tries to eliminate the excessive bicarbonate in the urine from the intercalated B cells via the pendrin, and this usually doesn't set the maintenance phase of the metabolic alkalosis. But there are some factors in which there is metabolic alkalosis occurs, and first is if you do not deplete the intravascular volume. So in such conditions that leads to the maintenance of the metabolic alkalosis, and because in such patients there is the inability to excrete the excessive bicarbonate in the urine, and secondly it could be due to the reduced effective arterial blood volume, for example in the patient with the heart failure or cirrhosis. And third cause is the patient with the chloride depletion state, and fourth cause is the hypokalemia, and the fifth cause is the renal impairment. Now we will discuss how this hypokalemia and the chloride depletion will lead to the maintenance of the metabolic alkalosis. So this is a diagram which explains how this chloride deficiency and the potassium deficiency maintains the metabolic alkalosis. So what did the in patients with chloride deficiency, so this macular denser cells, they will be activated. So they will sense that the tubular fluid will contain the less amount of the chloride, so they will be stimulated and they will secrete the renin, that will leads to the activation of the renin-angiotensin system, and this in turn will cause a release of some signals and some mediators that will cause the afferent arterial constriction, and that leads to the decrease in the GFR. So this is the mechanism. And another mechanism is that in patients with chloride deficiency there is an increased proximal H plus ion secretion, and as we know, if there is a increased H plus ion secretion in the urine, that will cause the maintenance of the metabolic alkalosis. And second is the potassium deficiency. How the potassium deficiency causes the maintenance of the metabolic alkalosis. So potassium deficiency, basically it affects both the PCT as well as the DCT. In the PCT, it causes increased ammonia generation, ammonium ion production, and increased H plus ion secretion. And in the distal tubules, it mainly causes increase H plus ion secretion. So in this way, this potassium deficiency causes maintenance of the metabolic alkalosis, and secondly it also causes increase in the renin, and the exact mechanism of it is not known. And now the third is when there is a renin angiotensin aldosterone system RAS activation, there is an increased aldosterone, and that will lead to the increased distal H plus ion secretion that will cause the further maintenance of the metabolic alkalosis. So this diagram is very important. And now in patients with hypokalemia, this is a repetition of the previous thing. There is a increased intertubular acidosis, and which stimulates the H plus ion secretion both in the PCT as well as DCT, and increase ammonia synthesis and excretion, and the bicarbonate reabsorption. So in this way, the hypokalemia causes the maintenance of the metabolic alkalosis. Now we see in the PCT there are the various pumps. On the tubular there are the two, one is the basolateral side and other is the tubular lumen side of the PCT cells. On the tubular lumen side there are transporter like H plus ATPase and the sodium hydrogen antipode. So this hypokalemia will cause the stimulation of H plus ATPase pump that will cause the H plus ion secretion from the PCT. And secondly, this hypokalemia will cause this intratubular acidosis, and which will lead to the breakdown of the water into H plus ion and the CO and the OH negative ions. Then this OH negative ion will combine with the CO2 in the presence of carbonic anhydrase type 2, and thus leading to the formation of bicarbonate, which will be reabsorbed into the peritubular capillaries along with the sodium by the sodium bicarbonate co-transporter. And there is another pump present on the basolateral membrane, that is the sodium potassium ATPase pump, and which causes reabsorption of 3 sodium in exchange for 2 potassium ions. Now as this H plus ion will be secreted into the tubular lumen, this will combine with the bicarbonate and to form the H2CO3, and in the presence of carbonic anhydrase 4, this will further break down to the CO2 and the H2O, which can be further passively reabsorbed. So inside the cell there is a carbonic anhydrase type 2, and in the lumen there is a carbonic anhydrase type 4. Now in the intercalated cells of the late DCT and the collecting tubules, there are two types of cells we know, the type A and the type B cells. Type A cells mainly responsible for the H plus ion secretion, and the type B cells mainly responsible for the bicarbonate secretion in the tubular lumen. So in the presence of hypokalemia, this hypokalemia causes H plus ATPase activation in the DCT also, and that will cause H plus ion secretion from the DCT, and thus lead to the maintenance of the metabolic alkalosis. Now there is in the type B intercalated cells, these cells they are mainly responsible in normal states, like the kidney excretes this bicarbonate via the Pendrin mechanism and in exchange for the chloride. But in patients with metabolic alkalosis, as there is a hypovolemia and there is a decreased effective arterial blood volume, that all this leads to the decreased chloride delivery to the distal tubules, and as we know, this bicarbonate is secreted into the tubular lumen in exchange for the chloride. So if there is a decreased chloride delivery to the distal tubule because of this hypovolemia, that leads to the decreased bicarbonate excretion in the urine, and thus the kidney is not able to correct this metabolic alkalosis, and thus this finally leads to the maintenance of the metabolic alkalosis in such patients. So if you want to correct this metabolic alkalosis at early stage, you should give IV fluids containing chloride, and that leads to the bicarbonate excretion in the urine and correct the metabolic alkalosis. So now we talk about why the urine is paradoxically acidic in patients with metabolic alkalosis. And the reason is these patients usually have the decreased extracellular fluid volume that leads to the decrease in the renal blood flow and decrease in GFR. And this decrease in GFR will leads to the increased sodium bicarbonate reabsorption in the proximal convoluted tubules and increased sodium reabsorption in the DCT, and thus leads to the increased H plus ion, the K plus secretion in the DCT, and this the potassium which is secreted in the DCT will further reabsorbed in the collecting duct in exchange for the H plus ion, and thus leads to the final secretion of the H plus ion secretion in the urine and leads to the paradoxically acidic urine. So in general, the patient with metabolic alkalosis should have alkaline urine, but this is the reason why this patient they have the paradoxically acidic urine because of hypovolemic states, and thus leading to the decreased GFR, and that will cause increased absorption of sodium bicarb that leads to the increase H plus ion and the potassium secretion in the DCT, and in the collecting duct there will be the H plus ion secretion in exchange for the potassium reabsorption, leading to the paradoxically acidic urine in such patients. Now we will discuss about the diagnostic algorithm in patients with metabolic alkalosis based on the spot urine and the spot urine fluoride and the potassium concentration. So you should see the urine fluoride and the potassium concentration. If the urine fluoride concentration is less than 10 or more specifically less than 10 or less than 20, in such patients the cause is usually the gastric fluid loss and the diuretics and the post hypercapnic states and the villus adenoma and the congenital chloriduria. And in patients in whom the urinary fluoride is more than 20, in such patients you should see the urine potassium concentration if it is less than 30 or more than 30. If it is less than 30 milliequivalent per day, the usual cause is the laxative abuse, and if it is more than 30, then the cause is you should see the blood pressure of such patients. So the causes of increased potassium excretion in the urine, they can be the laxative abuse, second is Bartter or Gitelman syndrome, and third is diuretic abuse, and fourth is primary aldosteronism, and the fifth is Cushing syndrome, and the sixth is this renovascular hypertension or JGA tumor, and seventh is malignant or accelerated hypertension. So depending on the level of the plasma blood pressure and the plasma renin, plasma cortisol, and the high unilateral renal vein renin, these causes can be divided into various categories. So if the blood first you should see in those patients who are having urinary potassium more than 30, blood pressure should be assessed. If it is blood pressure is low or normal, you should think of Bartter syndrome or Gitelman syndrome or the diuretic abuse. And if the blood pressure is on the higher side, then you should measure the plasma renin. If the plasma renin is high, then the cause is Bartter Gitelman syndrome or the diuretic abuse, and if the plasma renin is low, then the cause is primary aldosteronism or the liquorized injection. So but if the plasma renin is high and the blood pressure is also high, in such patients you should check the plasma cortisol level, and if it is high, then the Cushing syndrome, and if it is normal, then you should check the unilateral renal vein renin levels, and if it is higher, then it is renovascular hypertension and JJ tumor, and if it is not high, then the cause is malignant or accelerated hypertension. So what are the clinical features of metabolic alkalosis? So such the features can be due to the ECF volume depletion. Such patients, if the cause is due to the extracellular fluid volume depletion states, the patient can have symptoms like weakness, lethargy, and muscular cramps, and thus patients can present with the paresthesia, tetany, and neuromuscular irritability, because such patients usually have associated hypocalcemia and hypomagnesemia. And secondly, these patients are more prone for cardiac arrhythmias because of hypokalemia, and they can present with an altered mental state also. So so all the causes can be divided into the two types: saline responsive alkalosis and the saline unresponsive alkalosis. So if the urinary chloride level is less than 10, the causes we have already discussed, like vomiting, nasogastric aspiration, and diuretic use, and post hypercapnia, the villus adenoma, bicarbonate treatment of organic acidosis, and the potassium deficiency. So all these causes will respond to the normal saline. And if the urinary chloride level is more than 15 to 20, and the causes can be categorized as primary aldosteronism, Cushing syndrome, renal artery stenosis, renal failure plus alkali therapy. Those patients with the renal failure, and they are giving the alkali therapy and they develop the metabolic alkalosis. And in the normotensive patients, the causes can be the magnesium deficiency, severe potassium deficiency, Bartter syndrome, Gitelman syndrome, and the recent use of diuretics. So how to treat such patients? So the patients with saline responsive alkalosis should be given the normal saline, and they usually require 3 to 5 liters of normal saline for the treatment. And we can also use the intravenous hydrochloride, and there are the indications for the treatment of intravenous hydrochloride when the pH is more than 7.55, and when the patient is having cardiac arrhythmias, and when the patient is having hepatic encephalopathy, and when the patient is presenting with altered mental state, and the patient is having digitalis cardiotoxicity. And the amount to be given can be calculated as 0.5 into body weight in kg multiplied by desired decrement in the bicarbonate, and the rate of infusion should not be more than 25 milliequivalent per hour, and you should frequently monitor the ABG and the electrolytes, and the goal is not to reduce the pH less than 7.5. And the other therapies for metabolic alkalosis are the ammonium chloride. However, it is contraindicated in the patient with the renal and the hepatic failure, and we cannot give more than 300 milliequivalent over 24 hours. The next therapy for the saline responsive diuresis, saline responsive alkalosis, is acetazolamide, and this should be given in the patient with the adequate GFR, and it basically inhibits the carbonic anhydrase in the PCT, and thus leads to the excretion of sodium bicarbonate. And however, we should monitor the potassium during the treatment, as it can lead to hypokalemia. And the next line of therapy is the dialysis. If the medical treatment is not able to correct the metabolic alkalosis, then we need to dialyze the patient. And the next line of treatment is the villus adenomas, and such patients require the surgical removal. Next is, if the patient is having congenital chloriduria, then the treatment is usually the correction with the fluids, chloride, and potassium. And we should also prescribe the proton pump inhibitor to such patients in order to decrease the HCl secretion. And usually the antidiarrheal therapy is not effective in such patients. And in the patients with Liddle syndrome, the usual drug of choice is amiloride, as it inhibits the ENaC channels, and the main mutation in the patient with the Liddle syndrome is the gain of function mutation in the ENaC channels. Then if we talk about the saline unresponsive alkalosis, in such patients, if the patient is having severe potassium deficiency, then we should correct the potassium deficiency. And if we are giving by the peripheral line, the maximum potassium we can give is 20 milliequivalent per hour, and if we are giving by the central line, the maximum potassium we can give is 40 milliequivalent per hour. And if the patient is having Gitelman syndrome, then you should use potassium sparing diuretics, as there is a loss of potassium in such patients. And drugs like potassium sparing diuretics they are used, like the amiloride, triamterene, and the spironolactone. And although amiloride is the first choice in patients with Gitelman syndrome. And if we talk about the Bartter syndrome, in Bartter syndrome, there is the activation of RAS and increased prostaglandin. So we should give the ACE inhibitors, which will decrease the aldosterone. And secondly, we can give the prostaglandin synthesis inhibitors. And as this patient, they also have the potassium hypokalemia, so potassium supplementation is often required. And if these patients, they are diagnosed with the adrenal or any pituitary tumor, then the surgery is the treatment of choice in such patients. And in Gitelman syndrome, such patients, they also have the magnesium deficiency, so you should correct the magnesium deficiency in order to correct the metabolic alkalosis. And if the patient is having severe potassium deficiency, we have already discussed it earlier. So this completes with the treatment of metabolic alkalosis. Thank you.